Sir.
Yes, warm welcome to the another session of Pediatric Orthopedic Active Learning Session. And in this, we are connecting the internationally renowned pediatric orthopedic surgeon and the fellows who are getting training in India, Bangladesh, Sri Lanka, Pakistan, and many other countries. Today, we are very fortunate to have Professor Scott Kozin with us. He is a surgeon par excellence, but over and above that, he is a great human being and he is a great philanthropist. And he leads a program called Touching Hand, where they provide the excellent treatment to the children from the developing countries or the countries where they cannot get a good treatment. So they bring these children to USA and provide the treatment. If you have not heard his lecture, I request all of you to listen to his talk at the Knowledge and Wisdom webinar series, again run by OrthoTV. And few weeks back, he gave a wonderful lecture how to create a team for philanthropy. So that's over and about that. And now I request Professor Rujuta Mehta to introduce our speaker. He is going to speak today on the secondary management of brachial plexus birth palsy, which is a field where the treatment strategies are evolving, and he's going to tell us about the current strategy. So for the introduction, over to you, Rujuta.
Thank you, Dhiren bhai. And it's an absolute privilege to be able to introduce and say a few words about Dr. Scott Kozin. He actually needs no introduction. He is really very well accomplished and well known in the field of hand surgery. But for the record, Dr. Kozin graduated from the Duke University in 1982 with a degree in computer science and then completed his medical school at Hahnemann University in Philadelphia, followed by orthopedic residency at the Albert Einstein Medical Center and a prestigious fellowship at the Mayo Clinic on Hand and Microvascular Surgery. He's currently the chief of staff at the Shriners Hospital, Philadelphia. He's published over 100 articles in peer-reviewed papers, mainly on the care of children and various diagnoses. He travels to developing countries to operate on children in need. He's been the past president of the American Society of Surgery of the Hand and many others, and received the Wayland Medal for honors a scientist who has contributed to a body of research and advances in that field. He implemented the Touching Hands project which Dhiren bhai spoke about. And with that, I think he is akin to being an institution in himself and started a movement that has really benefited so many needy children across the globe. He has a lot of personal special interests also, but definitely enjoys food and travel a lot. And behind all this multifaceted personality is a surgeon who has a deep thinking core and implements all his ideas and only enhances improvement of the care of the hand. So over to you, Scott, for clearing all the concepts and making us understand what should be done for brachial plexus birth palsies. Thank you.
Thank you. So thank you for that kind invitation. Is my audio okay?
Yes.
Okay. I'm sorry I'm a few minutes late. I do apologize. I just got back from Bhutan, of all places, with lots of food and travel, and I'm trying to catch up in my practice. But it's a privilege to talk about brachial plexus birth palsies. So just to give you a sense about how many children we see with this diagnosis, in any given year, we see about 200 to 250 new children with brachial plexus birth palsies. I saw a few this morning. And what that has allowed us to do is really think about this problem, whether it be primary surgery, which we're not going to speak about today, or secondary surgery, meaning tendon transfers, osteotomy, fusions, etc. And what I'm going to talk about is all these secondary surgeries. So the title of the talk is Brachial Plexus Birth Palsies, meaning kids who are injured at the time of birth, not traumatic plexus from other reason. I'm going to talk about the shoulder, which is the primary area of pathology. And then I'm going to mention the other joints. So we're going to go through them individually. So the first most important point with reference to the shoulder is shoulder deformity occurs early and it occurs frequently. And as orthopedic surgeons or plastic surgeons or neurosurgeons, our responsibility is to recognize the development of this deformity early. The key is clinical examination, which we'll go over. The take-home points is that plain x-rays are not helpful. The kids are not ossified, so therefore a plain x-ray is useless. It's useless to the point that in our practice, we don't even x-ray the shoulder looking for glenohumeral joint dysplasia, which we'll define. And if you can make the diagnosis early, there are more treatment options that are more effective than later treatment options. So we need to make the diagnosis early. So how early is early? If you look at it, it's really early. This is a study that looked at 17 shoulders and 16 kids. The children's less than 5 months of age, so very early on in life. They had a normal appearing glenoid in 5 of 7, but in children older than 5 months, there was normal glenoid in only 2. This is a problem. We need to prevent this deformity from occurring. So the next question is, what happens? Like, why does it occur? So for whatever reason, we as human beings are constructed that our internal rotators are much stronger than our external rotators. That's our normal anatomy. We have many more internal rotators that are stronger and more robust than our external rotators. So what am I talking about? This is our normal shoulder balance. So if you look at our internal rotators, which are on the left side of the screen, you have your latissimus dorsi.
Outlook email.
Uh-oh.
You turn to na library में जब login करवा चाहो ना तेरे अरे auto है
Darren's going to mute him, I think. Yeah. You have your latissimus dorsi, you have your teres major, you have your subscapularis, and you have your pec major. All of those muscles are internal rotators. In terms of our external rotators, if you think about it, it's just your teres minor, which is your main external rotation when your arm is at 90 degrees of abduction, or your infraspinatus. So already there's this subtle imbalance that occurs in us without a brachial plexus injury. Now you take a brachial plexus injury that affects the C5 and C6 nerve roots, and this is what happens. We lose our innervation of the teres minor, and we lose our innervation of the infraspinatus, and all of a sudden, we have this marked propensity to develop internal rotation contracture. So initially, the babies will position internal rotation, but not have a contracture. But left untreated and unmanaged, over time, they develop a contracture with loss of passive external rotation. Here's the problem. So we know this occurs and we need to prevent the problem. Again, on the left side of the screen is obviously all the internal rotators that are manifested as this big person. And on the right side of the screen is the external rotators, which is the little teeny person. So how do we make the diagnosis? The most important diagnostic tool is our physical examination, just like most of orthopedic surgeons. So physical examination, then ultrasound, which we'll talk about, then MRI. Now, what's important to note on this list, there's no X-ray. X-ray is not even a diagnostic tool in our practice. It's a waste of time, it's a waste of radiology, and it's very unreliable because I said before, kids are mainly cartilage. So what's the physical examination finding? As the shoulder rides out the back of the joint or the glenohumeral joint, so the humeral head rides out the back of the socket, the humeral segment looks shorter, similar to a Galeazzi sign for hip. And we always say the shoulder and hip are analogous. So if you have DDH of the hip, you lose abduction and external rotation. You have glenohumeral joint dysplasia, you lose external rotation. Now, the external rotation that you lose is with the arm in adduction. The arm in adduction is a better assessment of passive and active external rotation than the arm in abduction. So you want to measure this in adduction. As the shoulder becomes more and more dysplastic, you also have asymmetric skin folds, again, akin to similar to DDH. We looked at this years ago. It's hard to believe it's now been 20 years. But in essence, once you get past neutral, so if my arm is tucked in at my side and my arm is straight ahead, that would be 0. If I can't stretch the arm into passive external rotation more than neutral or more than 0, if you look at our data, that is very consistent with almost always the imaging studies showing glenohumeral joint dysplasia. And glenohumeral joint dysplasia is defined as glenoid retroversion, meaning it's tilted backwards, and humeral head subluxation. So like I've said for the 3rd time, plain x-rays are not helpful. So in our office, we use ultrasound as a screening tool. So if anybody feels that the shoulder is getting tight, we just bring in the ultrasound. We don't use a radiologist. We do the examination ourselves. So here's what it looks like. Ultrasound, child sitting on the mom's lap, as you see here. A posterior portal, meaning that's where the ultrasound's positioned. And then this is Dr. Z, my partner, Zlatilo. And what he's going to do is manipulate the shoulder into internal rotation, where the humeral head should ride out the back, and external rotation, where the humeral head should reside in the glenoid cavity as long as the joint is reducible. So here is what it looks like. So let me just spend a moment here, right? So in external rotation, the humeral head translates anterior, and in internal rotation, the humeral head comes out the back. Now, this phenomenon happens to all of us. We just don't move out of the back of the joint in internal rotation, like this child with glenohumeral joint dysplasia. So you can see here, the head reduces, which is a reducible glenohumeral joint, but in internal rotation, it pops out the back. The white that you see is the ossification center, and the black you see is all the cartilage that you don't see on plain film. It has been talked about that by ultrasound, you can measure the humeral head subluxation, and you can measure the glenoid retroversion, called an alpha angle. We looked at this back in 2017, and what we found was that we, amongst all of us, were able to demonstrate humeral head subluxation, but our measurements for glenoid version were unreliable. So in our practice, we don't use ultrasound to look at glenoid version because it wasn't reliable. We use ultrasound to look for humeral head subluxation. If we want to look at the glenoid configuration, we need an MRI. So here's an example, right? So there's a normal MRI on the left and an abnormal on the right. So let's spend a second talking about the normal MRI on the left. We explained to the parents that the scapula and the glenoid is like a golf tee, and the humeral head is like a golf ball. And the golf ball should sit directly on the golf tee. So you can see that a line that goes through the glenoid should pretty much bisect the humeral head. It's not perfect, but it's close enough. And the glenoid retroversion should be about neutral. Normal glenoid development is from -2 degrees retroverted to neutral by 10. So -2 to neutral by 10. If you don't have this balance around the shoulder, that normal glenoid retroversion doesn't correct over time. And if you have a preponderance of internal rotators, you end up with glenohumeral joint dysplasia as depicted on the right side of the screen. So if you look at the line that goes down the scapula, it doesn't even come close to bisecting the humeral head. So the golf ball is off of the tee. If you look at the glenoid, it's incredibly retroverted. So there's 2 different facets on the glenoid, but the posterior facet is very retroverted. So again, I wish I was in front of you to go over this. There's a normal on the left and an abnormal on the right. And what we typically do in our children, we like to get MRI of both shoulders so we can show the parents this is what it should look like on the left, and this is what it looks like on the right, and we need to fix the situation on the right. So if we can make the diagnosis early, like you saw in the ultrasound that Dr. Z performed, it allows opportunities to prevent true surgical intervention. So there's non-surgical and surgical options. If the joint is reducible in the infant, So let's say the child is 8 months of age. There's tightness in internal rotation, but the ultrasound shows the joint's reducible. Then we're going to consider early Botox and casting, which we'll go over, and we'll see if we can resolve the imbalance about the shoulder. Now, remember, what Botox does is it weakens the internal rotators and allows time for nerve regeneration to regenerate the infraspinatus and the teres minor, and then restore relative balance about the shoulder. Although, like I said before, we're all imbalanced, but at least we have something on the external rotation side versus internal rotation side. And then we'll mention tendon transfers, what they do. So Botox and casting, as you'll see here, Botox blocks the receptor. It lasts for about 3 to 6 months time. Here's how we do Botox. If we are going to Botox, we want to Botox all of the internal rotators. So this slide shows the Botox being injected in the pec major. The child's under anesthesia. An insulated needle is placed into the intended muscle and verified by stimulation. Once we verify adequate placement, we inject the Botox. Now, let me just say a word about Botox. Botox is incredibly safe as long as you abide by the principles of how much units per kilogram, right? So we use up to 100 units, but it has to be 10 units per kilogram. If the child weighs less than that, you need to use less Botox. If the child weighs more than that, you can use more Botox. Then we'll inject the subscapularis, as you'll see here. So that's the second internal rotators. The needle is directed toward the scapula. Once you hit the scapula, you back off a little bit, you're in the subscap. You verify it by electrical stimulation, and then you inject. And then we'll inject the teres major and the latissimus dorsi and teres major. And then we put them in a cast. So we take advantage of the child being under anesthesia to put them in a cast. We cast them for 3 weeks' time because the Botox become very effective by 3 weeks' time. The Botox does not work right away, so you might as well put them into a cast, and then we see how they do over time. Now, how do you define success? This is such an interesting concept. So Mary Beth Izaki, who's a dear friend of mine, she looked at her results in 2016. So she looked at a fair amount of patients, number of patients, 50 patients, and she said that Botox and casting was successful about 70% of the time. But she defined success is that when you don't have to subsequently perform a surgical reduction of the joint itself. If you look at our results, they're the same. But as a parent, if I use Mary Beth's definition, that still requires my child to have surgery more than 30% of the failure. So we looked at success as saying, okay, if we really want to look at success, let's assume the child never needs surgery. If I'm a parent, that's a better definition of success. So no open reduction, no closed reduction, no surgical reduction, no tendon transfers, no nothing. And our results show that that only works about 16% of the time. So we tell the parents that Botox and casting works about 20% of the time, meaning your child will never, ever, ever need a surgery about his or her shoulder. Our results were best in those childs that had some maintenance of passive external rotation. If they were super tight, like less than 15 degrees of passive external rotation with the scapula stabilized in adduction, they failed. So we know a large proportion of infants will not respond to Botox and casting. So we've scaled back our results when we talk to the family. So as Churchill used to say, success is the ability to go from one failure to another with no loss of enthusiasm. So we still do Botox and casting. We give it one go. If they fail the first Botox and casting, then we'll move on to other options. Now, once there is an established deformity, now what does that mean? That means the joint's no longer reducible. So the ultrasound shows that the joint will no longer reduce. Once that occurs, regardless of the age of the child, they need to have the joint reduced by some form of surgical intervention. You can do it open, you can do it arthroscopic. We used to do a fair amount of arthroscopic. We transitioned to open, and I'll describe why in a second. Because if we put the ball back in the socket in young babies and young kids, the joint can remodel over time. So here's a case presentation. This is an arthroscopic case presentation. It's a 2.5-year-old child with loss of external rotation. So the child was tight. You can see the MRI, which shows that the golf ball is falling off the socket. So there's humeral head subluxation. And you can see that the glenoid is also retroverted, like the lines that are depicted on this slide. The procedure here was arthroscopic release. So let's just think about this. What are we going to do? We can balance the joint itself by releasing the main culprit. And the main culprit is the subscapularis. So this is looking from the back to the front. The arthroscopic probe and the arthroscopic cautery is put in from the front, and we're releasing the upper rolled border of the subscapularis until the joint is reducible. You do not want to release the entire subscapularis, because then you're going to jeopardize midline function. This is the inferior subscapularis. So here's the MRI before surgery. Here's the MRI in the cast. And you can see now the joint is reduced and the joint will remodel over time. Here's the clinical scenario. Sometimes there's an audible pop as the humeral head moves from the posterior facet to the anterior facet. And then you want to put them into a cast, as you see here. And then when you keep the cast on for somewhere between 3 and 4 weeks, and then get them moving. So our results of arthroscopic capsule release, we've done over 100 of these, show that the arthroscopic release reliably improves the alignment of the glenohumeral joint, meaning the version corrects over time, and the humeral head subluxation lessens. Now, what's interesting, if you look at their range of motion, reducing the joint and releasing the subscap will improve their external rotation. We thought that that concept would also improve their shoulder abduction because the greater tuberosity would clear the acromion, but we were wrong. That's the null hypothesis. So if the child truly needs additional overhead motion, you need to add a tendon transfer. So if you look, TT stands for tendon transfer group. Their range of motion improved to about 145 degrees compared to 120 degrees with isolated release. So if you want to improve abduction, you have to think about adding a tendon transfer, but you also need to think about, if I add the tendon transfer, meaning I take a latissimus dorsi and teres major and make them external rotators, am I going to jeopardize midline? Because life is all about balance, as is the shoulder joint. So here's an example. This is before surgery. On the top, glenohumeral joint dysplasia, humeral head subluxation, glenoid retroversion. Here it is at MRI follow-up. Looks normal. Here is her motion. Here's her abduction. External rotation, which is exceptional from the release. Here's external rotation. They all have trouble with shoulder extension, which we can talk about in the question and answer. And then importantly, even those kids with fairly bad deformity, if they're young enough, and young enough means less than 4, they were able to correct, but still were able to achieve better outcomes in children with less deformity. It goes back to my initial slide. You have to make the early diagnosis. And the early diagnosis is made by the physical examination and supplemented by the imaging studies. We currently now favor an open joint reduction. This is Francisco Soldado from Barcelona, because we figured out that over time, as the humeral head subluxes, the coracoid beaks. And the coracoid, because it beaks, can block humeral head reduction, or if we're able to reduce the joint, can make a stiff joint. So this is another child. This is a 2-year-old with right brachial plexus palsy, underwent microsurgery at 8 months of age, develops a tight shoulder. Ultrasound shows a humeral head subluxation, but ultrasound shows the head subluxation, but not the glenoid. Here's your MRI. So you can see on this MRI a couple things. The biceps tendon, which is the black dot in the groove, should not be that internally rotated. So that shows the humeral head is in internal rotation. And the line on the left side is pointing to the ossific nucleus, which should point to the glenoid. So it's very internally rotated. You also see on the MRI that there appears to be good turgor in the infraspinatus, not so much in the deltoid. So therefore, if you just restore the alignment, you should gain external rotation. It's the chicken and the egg principle. So what happened first? The humeral head subluxed, and then subsequently the infraspinatus reinnervated. So here's our current approach, and we have videos of this on our Little Arms website. Anterior approach, straightforward deltal pectoral interval, move the cephalic vein medial, find the coracoid, as you see here, release the conjoint tendon, release the pec major, get rid of the coracoid, and then identify the upper roll border of the subscapularis, like you see here, enter the joint, and then gradually release the subscapularis until the humeral head is reducible, just like we showed on the MRI, on the ultrasound when it was reducible. What does that look like clinically? Watch this. So here we're looking inside the joint. Sometimes when you look into the joint and the humeral head is out the back, you don't see any humeral head. So this is the subscapularis. The patient's in lateral decubitus, right? So the shoulder is up, the head's to the right, the belly is down, and the arm is to the left side of the screen. We're looking in the glenohumeral joint, and we see the glenoid, but we don't see the humeral head. Once we reduce it, watch this. Magical, right? So internal rotation, the head comes out, boom. External rotation, the humeral head reduces. This is one of the reasons that we're starting to favor this open release. One, you get rid of the coracoid, and two, you can watch the humeral head reduce, so you know it's reduced when you leave the OR. And this is what it looks like clinically, just like the arthroscopic picture. In, out, back and forth, right? And what about tendon transfers? Well, we know tendon transfers will improve abduction, like I said before. We've looked at this. Peter Waters looked at this when he was at Boston. And tendon transfers reliably produce this type of outcome. So you have improvement in abduction, improvement in external rotation, improvement in hand and neck, which is external rotation, no change in hand on spine, improvement in hand to mouth by the Malay measurements, and some reciprocal loss of internal rotation, which is what you would expect. And then our current body of research is looking at this in the motion capture lab, where we can measure scapulothoracic motion and measure glenohumeral joint motion. And if you're not careful, I'll talk all day about this because it's one of our huge areas of interest. But we know that there is definitely improvement in tendon transfers of their range of motion, but this is super important. Tendon transfers without opening the joint do not lead to remodeling. So if you look at this, this is a series of kids who underwent tendon transfers, thinking that that in of itself would rebalance the joint and improve version and improve humeral head subluxation, and neither one of them occurred. So now tendon transfers will stave off any further progression. So in kids with mild glenohumeral joint dysplasia, I think it's okay to stop it right there. Or in kids with a normal joint with lack of active abduction or external rotation, that's a good role for tendon transfers. But tendon transfers do not lead to remodeling. That's the take-home point. Now, there are other options, glenoid osteotomy, as you see here, and humeral osteotomy. Glenoid osteotomy, we don't know where it fits in the paradigm. For us, it's these reducible glenohumeral joints in older kids, and humeral osteotomy are those with established glenohumeral joint deformity in kids that are older than 8. So here's an example. And we know that derotation humeral osteotomies just shift the arc of internal and external rotation. This is our medial approach. We prefer the medial approach. Here's an example. This girl had very good abduction, but absolutely no external rotation on her left brachial plexus. She's 12. So she's too old for any attempted joint reduction. You'll lead to stiffness and pain. Here's her external rotation. Here's her trumpeter sign. And here's her lack of external rotation. We perform a medial approach. As you see here, this is the ulnar nerve. This is the intermuscular septum. We excise the intermuscular septum. We put a plate and screw on at least distally or proximally. We then remove the plate and screw and cut the humerus, and then we're going to rotate it, and then we're going to fix it. And here she is 2 months after surgery. As you can see, her trumpeteer sign is now resolved. She can touch her ear. She can touch the back of her head, and we have not jeopardized her midline. Now, one more point about tendon transfers, which I think is really important, is what about tendon transfers for the flail shoulder? They don't work, right? They do not work. So if the shoulder is truly flail and has limited range of motion, you cannot do a tendon transfer. Here's an example of a 7-year-old with a traumatic brachial plexus palsy. Obviously, it doesn't hurt because kids don't have pain from this, but it's totally unstable. And he also has no ability to bend his elbow. So what's the treatment in these children? We prefer a fusion or chondrodesis. So we're going to fuse the glenohumeral joint sparing the physis, use an external fixator. And you can see here, it's his left arm. It's now stable and fused. So now he has at least a stable foundation to work on. He still can't bend his elbow. We'll come back and do a free gracilis. In this case, we used intercostal nerves, and now we restored hand-to-mouth activity. So that's what you need to do for a flail shoulder. Do not waste your time performing tendon transfers. Even all the Saha stuff hasn't worked for us with a completely flail shoulder. Now, what about the other joints? I'll run through these in the last few minutes. We'll talk about elbow, forearm, wrist, and hand. Wrist and hand we're not going to really talk about. The elbow, to me, is a quagmire. It's so interesting because initially, these kids can't bend their elbow, right? And then subsequently, they develop an elbow contracture. So why does that occur? So Roger Cornwall and colleagues have shown that in babies, it can be a baby human or baby rat, when you reinnervate a muscle in a baby, that muscle doesn't grow like normal muscle. So it's called impaired muscle growth. So once the biceps reinnervates and the humerus grows, they develop an elbow contracture. We used to think it was due to triceps weakness. That's not true. It's due to impaired muscle growth. So we go from lack of elbow flexion in the baby to now an elbow flexion contracture. And in our case, prevention is the key. So therapy and splinting is way better than surgical intervention. And in this case, we're going to use serial static splinting by our therapist, serial casting, and we may add some Botox. But this time, the Botox goes into the elbow flexors, the biceps, the brachialis, and the brachioradialis, casting for 3 weeks, followed by serial casting. In terms of elbow flexion contracture surgical release, I think it should be avoided. I think the concept of lengthening these muscles is faulty because it's really a muscle problem. You maybe consider a muscle slide like a Volkmann's ischemic contracture, but it's a big operation and it's a long ride for a short slide. Now, what about if we're able to maintain passive range of motion, but there's inadequate recovery of active elbow flexion? So this is the opposite. These are the kids who have a 5-6 injury or C5, C6 nerve root injury and don't recover elbow flexion. Tendon transfers are the gold standard. Here's your options. Steinler, which is flexor pronator. Triceps, which should be avoided at all costs in children. It leads to very severe elbow flexion contractures. Pec major is an iffy operation, and for us, it's primary latissimus dorsi, which is our favorite tendon transfer to restore elbow flexion. And then in extreme cases, like I showed you before, it's a free muscle transfer. Latissimus examination, these kids are often skinny. You can see the latissimus coming down the side of the body. The other way to elicit the latissimus firing is to ask the child to cough. It's a good coughing muscle because it's an accessory muscle for the rib cage, and you'll feel it fire. Latissimus dorsi is mainly a C7 nerve root innervated structure. Here's an example. This is Adam, a 4-year-old with absent right elbow flexion. Here's his examination, good passive range of motion. Here's our technique. Again, there's a described technique on littlearms.org. We tend to take it with a skin paddle to monitor. So in this case, the head is to the right, the feet are to the left, the arms up in the air. The child's in the decubitus position. We're going to harvest it on its thoracodorsal pedicle. We're going to transfer it from back to front. We prefer to attach it to the coracoid, not the acromion, and then we're going to inset it into the radius. Here's outcome early. It's a really good elbow flexor. It's very long muscle fiber length, so therefore it works very well. And here he is much later with good elbow flexion. Great. So moving down the ladder, a couple more points. Let's talk about the forearm. It is the forgotten joint. We forget about pronation and supination, but supination is important for hand to mouth, for carrying a tray, for wiping your butt, and for accepting change. Pronation is important for daily activities such as typing your computer and feeding. Again, just like the other two, just like the shoulder and just like the elbow, prevention is the key. You want to get a reliable therapist. If they don't have adequate pronation, but passive pronation is available, we prefer we perform a biceps rerouting. So you convert the biceps from a supinator into a pronator. You just wrap it around the radius. And once there's fixed deformity, then I think you need to consider either an osteotomy of the radius and or the ulna. IOM release. Our current preferred procedure is a one-bone form. It's the most reliable as there's no recurrence. I'll show you one example. This is a WAD with a fixed supination deformity of well over 100 degrees. Here is his volar approach. We're going to cut the radius a little bit more distal than the ulna. We're going to transfer the radius onto the ulna, as you see here. We'll use the proximal radius as an onlay graft. So we're going to shorten the forearm segment, but this allows tremendous rotational correction. And then we're going to fix the distal radius onto the proximal ulna. Here's the x-ray once it's healed. So note how the proximal radius, which was cut a little bit more distal than the ulna, is now an onlay graft, and all four bones have just healed together. Here's his pre-op. Here's his post-op. Remarkable improvement in his position. And the very last thing when it comes to the wrist and hand is just like any other reconstructive ladder for any other nerve palsy. The ladder is wrist extension is most important, followed by lateral pinch, which is the second rung on the ladder, followed by grasp, and then subsequently release. And if you use the standard parameters that we use for brachial plexus or cerebral palsy or radial nerve palsy, you'll figure out these tendon transfers that work to restore wrist extension, first and foremost, lateral pinch for pinch, grasp, and then release, which is the most difficult to restore. And with that, Darren, I think I'm going to end. Thank you very, very much. Let me stop sharing.
Thank you, Scott, for an absolutely masterly presentation, really clearing a lot of our concepts. Let's set the ball rolling with questions. We have a question from Bhushan. He says, what is your lowest age for tendon transfers?
So the lowest age, we've done tendon transfers in children a year. So let me just back up. Let me take a second here. So you see a child who has early glenohumeral joint dysplasia, right? You picked it up on ultrasound. You do a Botox and casting, and it fails. They get tight again. Ultrasound shows a humeral head subluxation again. You have two choices. You tell the parents, you can try one more round of Botox and casting, which we know works 20% of the time, or you could proceed with early tendon transfers, which is more reliable and it's only one additional operation. So the youngest transfer we have done is probably at about a year. And we've done a few of them, maybe a dozen or so, but I think that's the option you need to give the parents. You can try Botox and casting again, or you could proceed with tendon transfer. Great question.
Okay. There's another one from someone who's not named himself or herself. In the one bone forearm technique, at what position do we fix the forearm in?
So it's a good question. So to do a one bone forearm technique, a couple things. They need to have wrist extension, right? If they don't have wrist extension, you really can't put them into pronation. Our preferred position is about 30 degrees of pronation. So if you're 30 degrees of pronation, that's the optimum position, just like in the kids we see with a radial ulnar synostosis. A little bit of pronation is probably the best position.
Okay, and now we have a follow-up question on the first one. Does physiotherapy after tendon transfer pose a challenge in a child as young as
Yeah.
1 year of age?
Yeah. So another fantastic question. So when we first started doing early tendon transfers, our therapists, and I work with 8 OTs, as you know, you've been here and visit
Yes.
our center, right? They said to me, no way, you can't do it. And I'm like, well, I have no choice. Either I let the child develop more and more deformity, or we do something to prevent deformity. And lo and behold, they rehab fairly easily. Their brains are more plastic. They kind of just get it. I don't know how they get it. So the rehab in our 1 and 2 year olds after tendon transfer has not been particularly more challenging than our 4 or 5 year old. Good question.
One from me. After we've done everything is rebalanced and we've done taken a conjoint tendon, parents often come back saying that now we don't like that scapula sticking out behind. So
Yeah.
what do you offer them for that?
Yeah. So I think it's worthy for the trainees to spend a second talking about the scapula, right? So we used to think that the scapular winging, whatever that word means, right, or hypermobility, was related to a nerve injury to the parascapular muscles, whether it be the rhomboids or whatever, right? That we were wrong. Again, I've been wrong more than I've been right? Because our lab has shown that the reason that these children move their scapula so much is because their ball and socket motion is not normal, right? So what does that mean? We can't fix it. So unless the child gets more and more ball and socket motion, they're always going to wing their scapula, right? But we need to dispel the belief that the scapular hypermobility or winging is related to a neurologic injury to those muscles that move the scapula. It can be, but the vast, vast majority of kids still have innervation of their parascapular muscles. Because remember, you'd have to avulse all those nerve roots to lose innervation, and that doesn't happen very often, but it's mainly just due to the glenohumeral joint. So even at a young age, they move the scapula all over the place. I actually tell parents, I get it, it bugs you, it bugs your therapist. It's not a bad thing. It's allowing your child to do more than they could do if we did something to stabilize the scapula.
And as a follow-up question to this, do you think it would be the degree of that scapular hypermobility would be less if we used only the lat and not the teres?
I do. It's a great, right, because so it's a rhetoric question, right? But for the trainees, right? If you think about it, the lat comes from the rib cage, right? And does not really attach to the scapula. So if you transfer the lat to the humeral head, you're not connecting them together, right? But your teres comes from your scapula. So if you move your teres and you attach it to the humeral head, you're linking those two structures, right? So we think that would lead to increased scapular mobility. Pepe Barrero, who's an old name in brachial plexus, he used to actually release a little bit of the teres from the scapula because that was his thought. We don't know, we could look at it in the lab, but it'd be hard to look at, but it's an interesting question. I think the answer is yes, it does, because you link the two structures together.
Yeah. And just one more, if I may be allowed to indulge a little, since it's my favorite topic too. How soon do you think the shear deformity, which only one author has been speaking about, the scapular hyperelevation and abduction and rotation, how soon do you think that sets in as a resultant of the subluxation?
Yeah, I don't, we don't use the shear deformity. There's clearly a deformity. We don't use that acronym. That I know I know that's used here, and I know it's used in India also, actually.
No, only in a few centers, but yes.
Yeah. I thought Raj's group used that terminology.
They do.
Yeah. But I think the concept still is that these kids are plastic, and the deformity, which starts with the glenohumeral joint and then leads to all these other deformities, does occur very early, extremely early.
So, because I've seen a couple of them happening, say, even as early as 5 and 6 months.
Yeah,
and that's what sent me thinking that why does it happen so soon?
Yeah.
We have a question from Dhiren by himself. So let's
Yeah.
have that, and then the other question from Siddharth.
Yeah, the Scott, like you said that the shoulder is like a hip joint. In hip joint, when we see a DDH at a later age, we understand that acetabular is not going to remodel, and that's why we
Right.
carry out a acetabular procedure, whatever may be the osteotomy, but we try to improve the anatomy of acetabulum. Now, does that apply to glenohumeral joint, that when child presents late, probably with reducing the joint, the glenohumeral joint, we may not get the remodeling of the glenoid. And in that
Yeah.
case, what is the role of glenoid osteotomy?
Yep. So you're exactly right. So we don't know this, but we have stolen, I hate to say stolen, we've taken some of the data from the hip and applied it to the shoulder, right? Same thing, right? So up to the age of 4, they can probably remodel. After the age of 8, they probably can't. And 4 to 8 is a tweener. So we've taken the same type of approach. We don't know it, but we've taken the same type of approach, right? So in an older kid in our practice, that the head still somewhat reduces, right? And there is deformity of the posterior glenoid. That's our indication for glenoid osteotomy. If the head is sticking way out the back and doesn't go anywhere, when we try, we won't do a glenoid osteotomy. We'll move to the humeral osteotomy like we discussed. But we have done older kids like 12, right? Where the humeral head kind of goes back in. The CT scan, which because you use a CT in an older kid, or MRI, shows there's a posterior facet, but it's not that deformed. That's the kid we're doing the glenoid osteotomy. But we have no data. I just want to say that we don't have any data to support it, but that's our current approach. I wish we had more data, but I don't know.
Well, people are waking up now to questions. So
Yeah, I just
I'm
saw
going to
that.
take someone's question earlier, actually. What is the position of immobilization in a cast? Does it vary on a case-to-case basis? And then
Yeah.
we'll come back to Siddharth's question, because otherwise we'll have to have Scott taking lecture all over again.
So no, the casting is a really good question, actually, right? So like I said in the beginning of the lecture, we know that the best way to reduce the glenohumeral joint is in adduction, not abduction, right? So you want to put more and more adduction. Now you can't put a cast on with the arm completely adducted. It's not possible. But if you can get them as adducted as possible and in external rotation, that is the best position to reduce the glenohumeral joint. Now, when you add a tendon transfer, then you got to put them up higher just to take the tension off the tendon transfer and external rotation, right? But the point still is, in the younger kids, like the babies, we try and get as much adduction as possible. And if you're not sure that the glenohumeral joint is reduced, just do an ultrasound at the time of surgery, to make sure that glenohumeral joint is reduced in the relative position of adduction you're going to cast, right? So Roger Cornwell, who you heard me mention before, he always does an ultrasound of the shoulder after he puts the kids in the cast to make sure that the joint is reduced. We don't, because we've learned from our data that I can tell whether it's in or not. And Dan can tell just by clinical examination. If you have external rotation of 60 degrees, when the arm's in adduction, that joint's reduced. Trust me. But if you have external rotation of 30 degrees in adduction, you may not be sure, and you may need to do another ultrasound to prove that it's reduced.
So in India, we don't really have access to ultrasound that easily, because you have to register with the government and license yourself because of the PCP-NDT Act, which came into force to prevent female feticide. So hence we also have to rely on clinical parameters. And thank you for saying that.
Yeah.
Okay. There's a
Just a
question from
counter
Siddharth
question.
Kamath.
Yeah,
What
Rujuta,
would
just
you
a
do
question.
for, just a minute, Dhiren bhai, let's take it because he's been asking for a
Yeah.
long time. What would you do for shoulder abduction paralysis, pure shoulder abduction paralysis?
So if you look at a completely flail shoulder, like I showed in the video, nothing's worked in our hands from a tendon transfer standpoint. Nothing. right?
No, I think what he means is if the external rotation is good, but it's just only a C5 injury.
Oh, an isolated C5 injury. So it's a great question. I still feel the same way. So I think if you, let's just talk globally, right? Your tendon transfer, right? What it primarily does, it helps depress the humeral head so the deltoid can take over. That's what it really does. It doesn't really act as a really good shoulder abductor, right? So unless you have a deltoid, which I'm at C5, I don't think tendon transfers are effective. I think those, and the kid we just saw this morning, he had about 30 degrees of abduction. That's it. He had extra rotation. He had no glenohumeral joint dysplasia, but he had 30 degrees of abduction. I don't think tendon transfers work. I mean, I'd love to know what you guys think. I do not think that tendon transfers are strong enough or the vector is the right angle to take somebody who only can abduct to 30 degrees and get them higher. It just has not worked for me. And I've also tried one more thing, and I'll stop. I've also tried, the trapezius advancement, right? And again, I don't know. What can I tell you? I can't get it to work. I cannot get it to work reliably to really give abduction that's worth that operation.
Yeah, I agree. We've even tried a levator scapulae in addition to the, but that's all. One case here, one case there, but add a trapezius and a levator scapulae in.
I even tried the ETO thing. So ITOH, I think that's the way you spell it, where you take the lat and you pass it and you flip it and you make that into a deltoid. And that's a big operation. That's a ginormous operation. And I've just not I've not achieved results that I think are worth it.
Okay. Dhiren, sorry, I interrupted you.
So like continuing the same, what Dr. Rujuta said about that, we don't have an ultrasound in the operation theater. But once the cast is given, how do you see across the cast with ultrasound? Because that part is covered. So
yeah, two things about Darren's question, which are really important. So we are allowed to we have ultrasound here, but there are plenty of institutions in the United States that have similar problems, meaning the orthopedic surgeon can't do the ultrasound, which is craziness, right? We can do ultrasound better than the radiologist, but it's just segmented, right? It's just the way it is. So if I was in the OR and I wasn't 100% sure, I'd have to send the patient for an MRI. I would have to. So our first 24 arthroscopic cases that we did, this is before we were doing ultrasound, they all went and got an MRI, right? Just to see. And fortunately, we were able to tell 24 out of 24 that the glenohumeral joint was reduced. But you're exactly right. You need to get an MRI.
Yeah, true.
Not unless you're really lucky. Like there are certain places in the States now where they have an MRI in the OR, which would be really powerful. We don't have that.
Well, so I think we've had a really good stimulating discussion and we definitely could go on, but the clock is ticking and we're almost past some people's bedtime now. So
it's not my bedtime here.
It's
lunchtime here.
So
I gotta go back to work.
With the popular statement saying the dil mange more, which means the heart always yearns for more. We will take a promise from Scott to come back with some more things, and probably some of my students may discuss one of the papers that we're writing up shortly when you go to Canada next week. So
yep, I'm happy to come anytime. I really enjoy it. I really mean it.
Yes, thank you. I'll leave the formal vote of thanks to Dhiren bhai.
Yes, thank you very much, Scott, for a wonderful exposition on the topic. Really, it's the thinking which is very important, and I really want every fellows to understand that whatever like he says, like there is a reason for that, for changing the practice, there is a logic, and that's very important in practice, that you don't follow someone saying, but you think and then you modify your practice. And that was really a great example. Your lecture was really a great example in that direction. So thank you very much from getting a time from your busy schedule. And I know that you just returned from Bhutan, and so you are very busy in the practice. But thank you once again from bottom of my heart. Thank you.
Thank you. Thank you very much.